If you're joining as a panelist, I need you to take the camera on and also take take your mic that's muted off too. And if you're not using Zoom a lot, that's in your lower left-hand corner. But we're getting there. But I think we're gonna have to jump into it because we're already late. It's been a real amazing day in that we have had incredible number of sessions, more than ever, and we have had more registrants than ever, probably almost doubling the amount from last year. So that's a good sign. And especially in a year where we moved away from our ASC only and expanded it to general healthcare. So thanks everyone for joining. And for those of you who stayed on the entire day, I'm amazed. During this, you can ask questions in the chat box. I'm not sure we're going to be able to get to you, but we will call you afterwards. Each speaker and speakers, try to remember this, we're going to touch on your sessions in the order of the agenda, but we're going to be limited to about 3 minutes each person. That's how many sessions we have so that we could finish this before Thanksgiving. Also, all the speakers are going to become famous because this is going to be hosted on our Garfunkel YouTube channel. And everyone out there, this is the most popular question that we get.
Hey, honey, how are you?
Which is, when will we get?
Okay. Thank you.
Somebody's lighting up. Alex, I think you're lighting up,
What does that mean, lighting up?
meaning there's noise in the background.
Oh, okay. I'll mute. I'm sort of in a public place because I'm driving from a client site back home.
No worries.
But
No
I'll
worries.
mute it.
Okay, so we're going to start where the agenda started and where money matters. That's managed care. The queen of managed care, my partner, Deborah Silverman. I have 2 questions for you. And by the way, if you're out there in TV land, you want to ask a question, just call any of our offices, and they will be able to pass the questions on. Okay, so Debbie, there's this delicate balance when you're negotiating, whether it's on behalf of a practice or a hospital, where you want to stick to your rate proposal, but you also don't want to fracture relationships that could have been going on for years. So how do you strike that balance?
A good question, Andrew. I think from a health plan's perspective, tough contract negotiations is just something that they do day in and day out. And I don't believe that payers are all that worried about fracturing a relationship. Providers are much more concerned, well, if I push for something, will the plan take it out on me? And that's not something that I've really ever seen. As long as the provider has realistic expectations, maintains a professional demeanor, and treats the payers with respect. I mean, there's been occasions where it's gotten a little dicey, but I have yet to see, even with the most contentious negotiations, that at the end of the day, that everybody can kiss and make up and move on. It's just, again, to be professional, be respectful, and to keep your asks relatively realistic.
So that's interesting to me because you're right. I'm dealing with providers all the time and they're always completely worried about it, but I guess it's not as prevalent as they would think. Okay, so somebody asked this question. They're a new managed care leader. They just got a job. It's their first negotiation with a payer, right? You're limited by time as well. What's the one piece of advice you'd give them?
Before they go into negotiations, make sure that they've got the support of leadership, that they don't put themselves out on a limb, that the institution or the company is behind them, and that they're not getting ahead of their skis.
Okay, that's, all right, thank you. Going on to the next session. Um, that's the tension between federal policymakers and senior care. David, I listened to your presentation. I got a little depressed, right? These are tough days. So you talked about, well, the session talked about all the problems that are facing long-term care. As somebody who represents long-term care providers, how do you help them navigate a system that is so difficult, with limited resources? How do we make them less depressed about this?
Well, yeah, well, I'm happy that you watched the session, and but please, and hopefully somebody else did as well. But please don't be depressed, because that question really touches on the core of what we do. Every day we're attempting to help long-term care owners and operators navigate this system, a system that often feels unpredictable and more punitive than productive, trying to hold owners and operators down. So what we do is we always try to refocus on parallel tracks of efficiency and risk mitigation. So we can limit costs, but also we can limit costs now, but we can also limit long-term costs. So we're constantly working to combat these drains on time and resources and morale, which are all very real costs, and all things that the current regulatory framework imposes. And that's our day-to-day focus. But from a higher viewpoint, we're also focused on influencing the government to adopt a more rational and sort of partner-based model. Regulation should lift an industry up and not work to hold it down. And that's the hope, that the positive hope that me and my co-presenter sort of hope you leave with. And we can do that with a couple of things: strengthening the special focus facility program, giving a path to improvement instead of giving a permanent trap to operators, and expanding access to civil monetary penalty reinvestment. The civil monetary penalty reinvestment program, there is funding out there that can be used for workforce development and technology upgrades. We just need to unlock it. And finally, push for risk-based surveys nationwide, so high-performing facilities can be recognized and rewarded and not just buried in paperwork. But this is what we do every day. We see our clients' pain points, and we try to develop strategies to pinpoint opportunities within those challenges. So that's what we hope you leave with, a positive outlook.
Okay, and one follow-up to that, and then we're going to move on. By the way, speakers can cross-talk. Just remembering that Thanksgiving is a couple days away. So David, what do we do on reimbursement? Because I'm thinking about Debbie. What are we doing to help the reimbursement aspect of long-term care?
So it's another very pertinent question. Obviously, the owners and operators that we represent are on the front lines, and they want and really need a funding system that keeps pace with reality. It's the only real logical end to this, and that means Medicaid rates that truly cover the cost of care, that are updated regularly to reflect inflation, rising wages, and the growing acuity of residents. It also means protecting Medicaid from cuts. So we're constant champions of policies that support that. On an individualized basis, we help providers navigate everything from regulatory compliance to reimbursements to transactions to disputes. So our philosophy is always the same, which is just find efficient, effective, and profitable ways to help our clients care for our nation's most vulnerable citizens. So if we can help more providers strengthen their positions and thrive like that, then we're advancing our philosophy and we're positively affecting more people. And that's the goal of what I'm doing every day and what we do.
Now I see why you're in our DC office, so that's good. All right, moving on to ambulatory surgery center update. We don't have Bill Prentice, but we do have Greg Bloom. Greg, I'm going to be watching Brent's face when I ask you this question and you answer it. All of a sudden, Brent's like, uh-oh. Yeah, exactly. So, Greg, you, for those who don't know, you represent a lot of ASCs, specifically physicians that are forming de novos and joining existing ones. What are you seeing about the trend? Is it continuing? What's the story with hospitals partnering with physicians and ASC?
Yeah, thanks, Andrew. And no one could fill in for Bill Prentice, but I'll do my best. Um, we're definitely still seeing hospital physician partnerships in ASCs. We see it all the time. I think there are a lot of factors that lead to these relationships, and I think they're going to continue. Uh, First, there are payer-driven efforts to drive care to lower cost settings, ASCs, as opposed to hospitals in certain instances. Um, Look for Brent to back me or not on this. I think hospitals seek out these relationships for a number of reasons. I think they're looking to free up OR space at times, and they could take certain procedures outside of the hospital. And frankly, I think they look to continue to participate. They want to continue to participate in services that physicians are otherwise taking out of the inpatient setting. Um, and I think that physicians seek these partnerships for a number of reasons as well. They're looking for the institutional assistance in running a business. And quite frankly, the biggest one is negotiating payer contracts, which the hospital has to own a significant percentage to be able to do that to help. But I think physicians look for that and also to avoid opposition to establishing these centers in their community. So I think that trend is going to continue.
And just quickly again, keeping the perspective of physicians. Oh, sorry, Brent, do you want to say something?
Yeah, I mean, I would just chime in. I think it depends on the market. I think there are certain markets where you have to do business with a hospital in order to be able to maintain a surgery center. I think there are other markets where that isn't necessarily the case, and independent physicians can be successful. I think in the New York market, it's certainly possible to get a license from the state. I think it's hard to be competitive over the long term for a couple key reasons. Payer contracts, as Greg mentioned, plays a role certainly. But I think it really boils down to where are these physicians coming from and where's growth going to come from in these surgery centers? And it seems like in the New York market, it's either private equity backed roll ups of specialty care providers or hospitals. And the specialty care roll up companies have like a 5 to 10 year track record, and the hospitals have like a 150-year track record. So if you have to choose a partner, go for one that you think will be there for the next generation.
All right, well,
Like to highlight my Mount Sinai logo.
yeah. I was waiting for the Mount Sinai music to come up there, but yeah, okay. All right, well, you know what? Then let's stay with you for a second, Brent. In your session, which had a really brilliant moderator, it was investing in healthcare considerations when when utilizing hospital venture funds. But question: so let's say you have a physician who is very strong-minded. This is his baby. You want to invest in it, but he wants to keep control, right? Let's call it entrepreneurial control.
So this is an existing surgery center with the doctor that we want to bring into the
Not a surgery center. I'm moving on to, this is just, they've approached you with a company that they've started. You like the company. He wants Mount Sinai to invest, but he wants to stay in control. Can you accommodate that?
I think it depends. There are circumstances where there are individuals in the market that have something unique that enable them to be really strong in their independence, and we don't want to impact that negatively. But by and large, our strategy is to try to pull everybody under the tent and have them all working on the same platforms and the rest of it. And that gets really tough if the governance provisions enable them to have a fair amount of independence around decision making. So no, it's not impossible, but it's decreasingly common.
Okay, well, let me flip that now. Is it a warning sign to you or a red flag where the doctor says, listen, I want you to invest, I'm out. I don't want anything to do with it. Like, I'm just goodbye. I'll take my money and go to the beach.
Yeah, I mean, I think it's a warning sign because usually that physician is the engine of growth and productivity for that business. And if all of a sudden they're planning on walking away, it would have to be really clear on what's going to come in behind that individual in order to continue to push that engine of growth. So whether, that's a surgical specialty or something else, there'd have to be a pretty comprehensive team where it makes sense for that doctor to be acquired and exit and something of value to be left behind. And one of the things that I've seen that's been really challenging, using ambulatory surgery centers, because it was sort of the theme for the moment, you have a bunch of doctors who, have been very successful and seen their career through, and now are looking at the end of their career and trying to figure out what's next. And they have this expectation that when they exit, they're going to get this big multiple. They're going to get a big payday. And the bottom line is that the center is being evaluated on its current and future productivity. So if all of a sudden you see a bunch of septuagenarians who are going to exit the business in the next 3 years, it's really hard to justify writing that big check when effectively it's going to be a big empty box after they leave.
Right, an expensive box, right. Okay, thank you. All right, going on to my favorite topic, and the one that we got the most buzz about, the hot topics in HR. Lauren, I don't know where you are on this big screen. There you are. I got nervous when I saw your session, because you were talking a lot about the I-9 for immigration, and I wanted to ask you this on behalf of Garfunkel's HR, but I think it applies to everyone. What do you do if you're looking at the form after the person's hired or before they're hired and things are missing and it's incomplete? It sounds like this is a really big risk to all organizations, given especially the political times we're living in, where immigration is another hot topic. So how do you deal with that? It's missing.
Sure. Great question, Andrew. So that's one of the reasons we recommend that companies do audits to make sure that their I-9s are in compliance. And as I'm sure you heard us talk about, there's some technical violations that are fixable and some substantive that are not fixable, meaning you're still going to get fined even if you fix them, right? But no matter whether it's a substantive or a technical violation, if you discover that there's information missing or incorrect on the forms, it should be changed, because the penalties increase, or should be corrected. The penalties increase if you have a knowing violation or you have a second or third violation. But there's a few caveats when you're fixing, if you do these audits and you realize signatures are missing or information's incorrect. The employer section of the form can only be corrected by the employer. And let's say there's a missing signature or information's incorrect. When you correct that information, even if ICE hasn't come knocking on your door asking to see the forms yet, you still have to put in the date that you made the correction. You can't backdate the form to when it was originally given to you. So only the employer can fill out the employer section, and you need to make a notation of the date with initials when you're either correcting something or adding signatures that were missing. If you have a few corrections to make, sometimes employers will put in, an explanation of the corrections and a separate form. On the employee side, only the employee can correct a mistake that was in their section. So for instance, if I'm the employer and I realize an employee left out a piece of information, even if I know it, I can't put that information in. I have to go back to the employee, and the employee has to do the same thing. They have to correct the information with initials and a date, so we know when the form was completed. If an employee no longer works for you and you need to do that, then the employer can fill in that part with an explanation as to why they did it. But, you want to fix anything that's missing or incorrect, but with those few caveats, so you don't wind up having a situation where you're accused of backdating forms or putting in information that the employee should have put in.
Oh, thank you. Who knew? And because this session is recorded and will be out there on the internet, let me just say that my takeaway is that you've checked all of Garfunkel's I-9s and they're perfect. So thank you for that. Okay, Jackie, where are you? There, I see you there. So Jackie, we've used you a lot to help with HR issues for our clients. Question, can you give me an example of one like low cost initiative that makes employees feel happy, well, all the things we're trying to do?
Yeah, definitely. And Andrew, I appreciate you asking that foil as well, because I know that there were some heavy topics today, even, the I-9 ones that we helped to address. But thinking about ways to help your employees feel included, it's always going to be good business. We want to retain people who work hard for us. My personal favorite well-being initiative that I've received is just having my birthday off and not having to go into work on my birthday. That is something that can be spread out amongst the workforce and isn't necessarily going to impact you all at once, since those birthdays are scattered. Another initiative that you could think about is maybe flexible start times if that's something that your business can support. But really the overarching theme is to think through what your employees care about and how to address them as a whole person and provide supports that allow for their well-being inside and outside of work as much as possible.
All right, so maybe something. Pizza helps too. We just had pizza day today. So
Pizza's got a bad rap on LinkedIn right now, so you can do it, but
I wanted to
make sure to
cancel
pair it with something.
a lot of money. We got a lot of offices. Okay.
Now she tells us, Andrew.
Yeah, I know. Where was she before? Right, right. Okay. Bert. Uh, Bert and Adam Berkowitz from our bankruptcy department, who gave a session on bankruptcy and healthcare. Can a reorganization save your business? So first of all, let me be clear that none of our clients would ever even contemplate bankruptcy. It's absurd, but they do.
Just a passing thought.
Just a passing thought. But they do, yeah. Even though you've done like 3/4 of the hospital bankruptcies.
Right.
Yeah. So, but my question to you is, so you have a patient who owes your money, and then you get notice that they file for bankruptcy. Is there anything you can do? What should you do?
Well, I mean, what you need to pay attention because a misstep can be costly. I think we talked about one of the foundational aspects of bankruptcy is to provide a debtor with a breathing spell, to give them an opportunity to rehabilitate or correct their financial circumstance. One of the ways that's done is with the so-called automatic stay, which we talked about. The automatic stay prevents creditors from taking any action, from taking any enforcement action, collection steps, and the like. Even a phone call demanding payment is barred or stopped by the automatic stay. The question arises, how do you enforce that? Well, it's enforced with potential damage claims or penalties. So a breach or violation of the automatic stay, frankly, can be costly. So what needs to be done, obviously, whoever is overseeing patient collections and the like needs to be aware if notice comes in. And notice doesn't have to be written notice. It could be oral notice. It could be a letter from debtor's counsel, not necessarily a formal bankruptcy pleading, but if you become aware that a patient or creditor has filed bankruptcy, collection efforts have to stop. It's also important to understand what the nature of the underlying claim is because the claims can sometimes have differing priorities depending how they arose, when they arose. So seeking out, input from Adam or I as to what the nature of the underlying claim is, whether you have priority, when the claim has to be asserted, those are all things you need to be mindful of.
Okay. Being mindful of, I'm going to be doing this with a lot of speakers, so I'm going to start with Adam. Adam, give me 2 things that you're in an organization, it has to file for bankruptcy. Operationally, what are the 2 biggest impacts you're going to feel right away?
So, believe it or not, the biggest impact is going to almost be a sense of relief, and your operations are going to start to work even more smoothly than you would have anticipated. It's a little bit counterintuitive, but before you file, you're dealing with putting out fires on a regular basis. You're dealing with managing moment to moment to stay afloat. You're dealing with fear, uncertainty in your workforce, in your patient population, and the like. Once you file, you're putting out there to the world that you have a plan to go forward. You've freed up resources and cash flow to be able to address issues as they arise on a go forward basis. And it's reassuring to your employees, it's reassuring to the vendor community, and it's reassuring to the patient population that there's a plan in place for moving forward. And it allows all of those parties and interests to really have an understanding and envision you in the future, as opposed to addressing and dealing with the financial distress that sort of mired everybody down up until that point.
Okay, relief on filing bankruptcy. Interesting. Okay, next one. We got a lot of chatter responses. The whole world is, not the whole world, the East Coast is alive with RICO claims, and everyone being attacked under the civil RICO statute. I'm gonna try this again. Let's start with you, Alexa. Um, Give me a red flag it's a red flag to a payer that's gonna put your practice on that RICO chopping block.
So obviously, we addressed a number of red flags that may put you in danger of going on an insurer's, verification list and may put you on their radar. But I would say overall, the biggest red flag is going to be a large volume of billing, and especially if historically you have not billed a large volume for that particular insurer. So, say for example, Allstate, in the no fault context. Say if in the last, 3 years you've billed them collectively $100,000 a year, and then all of a sudden this year you've billed them, say, $5 million. For them, that's going to be a huge red flag, and it might put you on their radar.
Okay? Justin, I don't even know where you are. So
Right here.
There you are. Okay, gotcha. So in many states, in New York, they're called EUOs, in New Jersey, they're PIP examinations. What's the biggest mistake a provider can make? Again, because of time, mistake that a provider can make during one of those examinations before they adjudicate your claim?
Yeah, I mean, overall, I think the biggest mistake that you can make, and I've seen a lot of people do this, is go to these EUOs and/or answer any of the insurance carrier's questions without counsel present. You'd be surprised how many people think this is a formality. I can just show up at this EUO, I'll answer the questions, they'll take me out of verification, it's no problem. It's the biggest mistake you can make, because an attorney that is trained in RICO defense is going to understand what the carrier is looking for based not only on the verification notice that you got initially, but the questions that are being thrown at you. And a question that you may think is completely innocuous that you can answer in your sleep may be the thing that really puts you on their radar. And an attorney who's trained to look out for this is going to say, I'm going to direct the witness not to answer this. Or, this is the sort of thing that's outside the scope of the EUO counselor, and I'm going to ask you to move on. And really, the way you answer these questions in the EUO can make or break whether you get named into a RICO case at the end of the day.
Okay, and we know we've had clients as of late that have made that big mistake.
Unfortunately, we do.
Yeah. Okay, thank you. David Trasky, where art thou, former OIG official?
Right here.
Up, there you are, upper right. Yeah, okay. So, David, again, so give me one of the biggest mistake that a provider can get into or commit when he's being approached by a governmental regulator.
So Justin just stole my thunder, but I'll echo the same statement, right? Which is going it alone is probably the biggest mistake that I could say, because again, remember, the government regulators probably know more than they're letting on. They're especially trained to elicit information from you. And for most part, people, providers and others are not trained in that way. And so if you don't have qualified legal counsel there to help you kind of navigate the ropes, you have an increased likelihood of saying something that might get you in trouble.
But David, given that we used to appear in front of you, I have clients all the time say to me, but if I go in with a lawyer, it's going to look like I'm guilty. Do you ever take that position? Like, I mean, not now because you're on our side, but when you were on the side of the government, did you care if they had a lawyer? Did you draw a conclusion about it?
No, and in fact, in a lot of ways, having counsel on the other side of the equation makes for a smoother discussion and a smoother negotiation.
All right, well, that's good to know because we battle with that a lot. Okay, thank you. And I'm glad you're on our side. All right, next one, and we're over time, so we're gonna plow through. Recent trends in long-term care transactions. And thankfully for our long-term care group, there are a lot of transactions. Let me start with you, Alex. Wherefore art thou? There you are. Yep, got it. Okay, Alex, you talked about all these different kinds of programs that are increasing, Medicare Advantage, ISNPs. What are a few things that a payer can do, that an operator can do to make it successful when they join one of these programs?
Andy, can you hear me okay?
Yep, I got you.
Oh, I would say probably the biggest thing that any operator can do, or any agent or representative of an operator who's involved in an M&A transaction when you are on that trajectory for the deal, is to know your data, whether it's your client's data, your data, or the acquisition's data. The reason being that, of course, during a diligence process, you're going to be looking at, what's behind the curtain and what's, and all the information about the particular asset that you're looking to acquire or merge with. But I think it's got to be done in a way these days with a very strong look to the future. Meaning, if you're going to be adding an asset to your existing footprint, how do you, as the acquiring asset, if you're a long-term care company yourself, what do you have in place that's going to add to the acquired asset to be attractive to the particular players on the continuum of care? So in other words, if you're going to a new market, a new geographical market or footprint, will you be attractive to the particular ISNP in terms of, excuse me, the covered lives, the outcomes, and so forth? Same with ACOs if you're going into a new market and such. We talked, Ray and I talked about this during the session, but it's about almost doing diligence on yourself in a very prospective manner in terms of understanding what you bring to the table for that continuum. So I guess in a summarized format, it's about your data. Are you attractive to the different entities, and how will that translate into you pro forming yourself and the acquiring entity down the line? Will this make sense? Knowing the market you're going into, knowing the possibility of eligibility, of participation, and how is that going to translate into whether it contributes or takes away from being involved in the potential transaction.
Right. I like that phrase, due diligence on yourself. It's like a very yoga kind of thing, but I get you. Yeah.
Namaste. Namaste.
Yeah, exactly. Ray, I know I have trouble reaching you, so you seem quite busy in 2025. First of all, has it picked up in 2025? We're talking now about long-term care transactions. You're buying and selling of nursing homes and others, long-term care. What do you think about 2025 now that we're coming to the end, and what's your crystal ball prediction for 2026? You're on mute.
My bad. Sorry about that. 2025 started off, pretty slow, I'd say, for the first half of the year. The second half of the year has picked up quite a bit. And what I'm seeing, what's coming across my desk and what I'm hearing, I expect 2026 to start off and to be pretty busy. There's a lot of things that seem like they're in the works. The Fed cut interest rates 25 basis points today. There's potentially another rate cut in before the end of the year. That could, certainly will help with financings and people's interest in doing deals. So, again, I think the way things have evolved, and some of the uncertainty that was everywhere in the first half of the year is not quite as much now. And I do think people are looking to do deals. So I expect it to be busy.
So my takeaway is if you're selling or buying a nursing home, they should call you right away. So, okay, thank you.
We're always here.
Yeah, thanks. Okay, are valuations really bulletproof? When they fail and why? I found that to be very interesting. So, Jonathan, I'm going to give you a chance to pick on the lawyers. What do you wish? You don't have to be polite. What do you wish lawyers understood better about
Hey,
the process? Yeah.
I am going to be polite. I'm going to let my colleague Aaron answer that one. I think he's got some good thoughts on that.
Okay, Aaron?
Yeah, well, we're all kind of working for the client, and sometimes certain issues require a sober view of the facts. And I think quite often, if help with navigating that, it's sometimes left to the valuator to sort of find the path forward, which we often do. But I think it's just the care and attention of FMV is a question of fact. And so whenever the deal facts, the transaction sort of facts and circumstances are pertinent, and they're not sort of either all in the valuation or what ends up happening doesn't tie to the valuation, I think that's where the valuation starts to fail and break down. And it's just in everyone's interest to sort of pay attention through that process, such that those critical, any critical items or even hypothetical assumptions, we think this is how it's going to go, are circled back to and sort of made sure that they're checked off, such that the valuation you get and the deal you're doing,
tie together, comport with one another. And I know when everyone's moving quickly, and you get the valuation done and you're sort of on to the next thing, we're not, the person sitting in the evaluator's role isn't always there to catch information if it changes or sort of tweaks at the end. And so it's really just, more communication sort of cures a lot of ills with that.
And to redeem the lawyers, it's also important to remember that the lawyers can keep things privileged when, you might not want those communications that are so important to get, disclosed to parties that you don't want to disclose them to. So that's why we always recommend that consultants that do fair market values get hired by the law firm under a co-val, as we talked about in our session. And then you can sort of pick what it is that you'd like the outside world to see, as long as you disclose it in a way that says, this is what I'm waiving the privilege for and nothing else.
Okay, good.
That's right. It's a teaming approach, of making sure that everyone's managing risk and getting the right outcome and work product there. So.
Okay, and I think, Alex, sorry, you just got dethroned. I like the phrase sober view of the facts. It's like a great title for a novel. But Jonathan, because you turfed that question over to Aaron, I'm going to give you an impossible task. In 30 seconds, tell me how you actually decide. I've never understood this. How do you decide whether you're using, the cost approach, the market approach, or an income approach?
Okay, I'll try to do this quickly. So I think for every valuation, the goal of the evaluator should be to use all three approaches. But really, there are three questions that I think about, as we think about which ones can we use and should we use. So the first one is, can each of these methods be applied? So there are certain valuations where certain methods do not make sense. Like, for example, a contract. If you're looking at the value of, say, a management fee, an income approach probably in its normal form is not going to work. So can the method be applied first? So then once you've gotten through that question, the second question is, as you're doing the valuation, how relevant is the method? And this is really coming back to what are we going to pick at the end of the process? So how relevant is the method? An example of this could be if you're looking at a business valuation where there's significant cash flow, there's a lot of market transactions, a cost-based approach for that business value is probably not going to be super relevant. So that's an example of that, of how relevant is the method. And then the last question is, how reliable is the method? So, is the forecast of the earnings really aggressive? Are the market comparables limited? And so, is my market approach going to be less reliable? Is my income approach really reliable or not? So thinking about the reliability. And so once you've gone through these questions, then I think the answer becomes pretty clear. Okay, this method and this method are probably stronger than this other method. And that's how we end up relying on the methods to determine value.
Okay. All right, last session and then some wrap-up comments. The last session that we're going to talk about is MSO PC structures, which are happening all the time. Taylor, I'm going to ask you a question. There's been a lot of questions coming in, even one in the chat now, which we're not going to be able to get to, but the person who asked it can call me and I'll answer it. A lot of questions about private equity, okay? So I want to ask you a question about that. What are some, in an MSO PC deal, which is extremely common that's the structure, what are some red flags to look out for in those type of deals? And how should a physician kind of value those deals in an MSO PC arrangement?
So
Taylor?
fee structure problems are going to be a big area. So if you're dealing with, if you're seeing an MSO fee that is, let's say more than 25% of PC revenue, that could be a problem. What you're trying to look out for is, what does that indicate with respect to functional control? Because if you have an excessive fee as a percent of revenue, and it ends up resulting in some sort of profit margin, at the PC level that gets sucked away and moved to the MSO, it's creating this picture of, okay, the MSO actually has, probably an inappropriate level of functional control over the PC. With private equity deals, you want to make sure that the fee structure makes sense, that you're not seeing excessive levels of revenues that are, or fees that are going to the MSO. You also want to look out for things that relate to any sort of direct or indirect control over staffing or other areas of financial control. So anything that could impose or suggest some sort of control over the clinical staffing or the financial decisions that should remain with the physician over clinical operations.
Yeah, and I would just add, everyone was PC MSO crazed, just rolling them out like it was nuts. And regulators are starting, we have some cases in the office out where regulators are starting to look at this again. They looked at it like 10 years ago and did some things. And I think those relationships along the lines that you're saying, if all of the money is going up to the MSO, who's really controlling what? So there's a lot there. Kat, last question, where are you? There you are.
Hi there.
So I see a lot of information flowing back and forth between MSOs and PCs. Is anybody thinking about HIPAA and that's, all
Yeah,
that
that's a great question. So what I think in a lot of these situations that it's forgotten that the PC is a covered entity and that the MSO in their partnership is a business associate to that covered entity. So there needs to be a really strong BAA in place that controls what information is being shared to the MSO. And then just from a practical perspective, it's understanding that the MSO really should only be accessing that data that's kind of the minimum necessary. What is the bare minimum data that they need to do their function that's already outlined in the MSA or the management services agreement?
Yeah, I mean, it goes to the same point, which is PC and MSO can't just be collapsed as one. They're
Right.
not, especially, by the way, especially in some states. New York's terrible like that, and legislation is popping up. So I totally agree with you. Okay, we had, I don't know, 14 sessions, and it was a really long day, and there's two people who really did a lot. One, it's his birthday today. That's Miguel. You'll never meet him, and that's probably the best. He's been working all the electronics behind the scenes, so thank you, Miguel. And Beth, who had to deal with 400 special registrants. We love all of you, but some of you were quite annoying. But she dealt with you and didn't get upset. Really, really thank the speakers. None of you got paid for this. There's no advertising. It's just we pumped out a lot of education. So everyone should give themselves a pat on the back because we did a lot of great things today. We'll see you next year. I mean, feel free to close during the year, obviously, but we'll be up to our next seminar this time next year, and hopefully this time the Yankees will be in the playoffs. So thanks everyone, and have a great day.